I guess I never left, so that makes me a really old guy. And this other old guy here has so much knowledge in his mind that we all learn from him. So hopefully the two of us can share as much as we possibly can with you in the next couple of years. So what I did is I put together this slide, and I'm going to apologize up front that I hate to sit, so I'm going to have to move around. So I'm probably going to be over there more because I can't see if I do that. So what we're going to do in Module A, so again we've got A, B, C, and D. We're going to go through a review lecture today. I have the honor of doing that, which essentially means taking 15 days and moving them into roughly 4.5 hours, which is impossible. So we'll see how impossible I made it, and hopefully I don't go too fast. And please, if there's anything that doesn't make sense, let me know. But we wanted to start by refreshing your minds, and as Rudy used to say, switch on your brains. Once we get through that, we want to go through initial cases that hopefully we've prepared. What we want to do that for is to see what level everybody's at, because we want to take everybody to the highest level in their cases, their documentation, and make sure that we have exactly the information we need so we don't miss anything. A very smart comment when we're looking at TMD. Being from North America, being from Canada, it really doesn't exist there. Meaning, this is how dentists look. They don't look. And if they don't look, they don't see. Both Ellett and I had practices. I had at one point a practice that was almost all TMD and complex TMD. I chose to reduce that and concentrate more on prosthodontics, just straight up beautiful aesthetics and beautiful function. Obviously, I had to do a lot of TMD along the way. Our goal is to start off with the basics, as Christian said, build to level 2 where we get to more complex cases with TMD. At the end of this particular module, we're going to show a really good Ellett Hazard documented level 1 case. And then the homework for that will be correcting your cases, the initial one, from the level 1 ideal case that you see. We're going to have you make 3 pairs of models. Now, one will be kept at home, just to make Bruch checkers, and we're going to have you do those at home so you can bring them next time. The second one is going to be used for mounting a lower master model pin and the upper model, and we're going to do that in ICP and RP, which we'll be doing in the second module. And the second pair of models that you're going to bring with you will be to make a splint. So in Module B, this will be our most intense module, no doubt, clinically. We're going to be in the clinic for much of it. We're going to do, initially, everybody's going to do a condylography on their partner. Fortunately, we have 12 people. When we do the condylography, we're going to do bites. We're going to control the bites through each group. So we have 3 rooms with 4 people in each. We'll have 1 person doing the condylography, 1 person being the assistant, actually 2 people being the assistant, and each time we'll switch around. And that way, we'll be able to do a condylography in the morning, condylography in the afternoon, morning and afternoon, have everybody doing condylographies on each other. Once we have that, we're going to be mounting an ICP and RP. Then we're going to have Gamma will scan the models for us to be used in the future. And we're going to go over condylography and review that. And each time we're going to have associated lectures that we're going to put in based on what your needs are, based on what you're thinking that you want to hear more of. This is a new series of lectures for everybody, and we have put as much into it as we can possibly think of. But we also really welcome your feedback, because this is very important to us to make this as perfect for you as we can. And your homework for that module will be photos of the models, intraoral photos, photos from Bruch Checker, get a lateral ceph, CBT and MRI if possible. And what we're going to use that information for is your second case presentation will be of your partner, but you're going to bring your own documentation. So that will be case 2 that you have to present. Module C, yes, there's too many words. We're going to go over everything as I said, and we're going to do functional analysis in an analog way using the articulator, introduce the variator. We're going to compare analog and digital. We're going to talk about diagnostics and treatment planning, the wax up, the equilibration, etc. Ellen will be introducing gamma Cadius 3D, the scanning, analyzing 3D occlusion, the differential diagnosis. And ultimately our goal is to do two things. We're going to look analog, and I will upfront tell you that I'm completely analog. Ellen is a hybrid of analog and digital, and is probably one of the smartest people I know to understand what is good about digital and what is not good about digital. Digital is a machine, it's not a brain, and we have to use our brains. Your homework for that module will be preparing with the final case, hopefully from your office. Now we've got a lot of information. We want you to have an excellent case that you can bring, ideally to be treated, especially if you go to level 2, and study for the final examination, which of course will be in the module B. Again, we're going to repeat the analog that we talked about last time, add in what we learned about digital environment. We're going to do the STL file upload, maxillary cast control with MeshLab, we'll do segmentation, occlusal analysis, etc. So basically working in the digital environment at that point. We'll do the final case presentations, any review lectures that we need, and then the final examination. So that's basically the program. It's a combination of making you more aware of everything. We're going to be looking at treatment planning, using VTO, etc. So all the things that are in the document browser that you know are there, but we're afraid to ask. So what are our expectations? We talked a lot about what we should ask from you. In order to push you to get to the excellence that we want, our goal is to ensure that your documentation is as perfect as it can be. When we're going to progress to level 2 in treatment, it's essential that you have that. And all of you that have been treating, you know that if you miss one little part of information, it can have a significant effect. The appropriate cases for level 1 basically are prosthodontic cases, and they can include simple clicks, i.e. reducible clicks. More complex TMD cases we'll be talking about in level 2, once we've got everybody to that prosthodontic diagnostic level of level 1. And then the completion of the 3 cases. So case 1 will be the initial case, corrected. Case 2 will be your partner. Case 3 is one from your office. And as I said with that, at the end of session D, the test will be just on all the didactic, meaning all the lecture portions. We're just going to put together a test just to really see where you're at, but also to check ourselves to see how good we were as teachers. As I said, we really welcome your questions and your thoughts. So, before I start, any questions at all about the curriculum? Ellen, any comments?
No, it's
No?
fine.
It's good.
I agree with you.
Okay, so now the problem. Reviewing the basic curriculum. So a few months ago, Kristen says we should start day 1 with a review. And my first thought was sure. And my second thought was how do we take 15 days and condense it? So this is my attempt to condense the basic curriculum into the points that you need to know. This is a place that we will be living for the next little while. It's a place that I love, and coming here from Canada is a journey that I look very forward to. As I said, I met Professor Slavicek in 1988. We will reference a lot of things that he said. Certainly I think we all have some cool stories about him that I will share some for myself. What's very nice now is that VSIT is literally worldwide, as you know, with all of these different centers. Yes, I did make Canada the biggest one. We talked about this when we were introducing, but issues with occlusion lurk in every segment of dentistry. I'm so excited that we have a lab technician and that we have 2 orthodontists here, because I think that interdisciplinary dentistry, we have to work together always, because TMD issues, occlusal issues, just basic function require all of our inputs. Our goal, when we graduate, I'd say we basically have about vision to CDE. Our goal is to get you now below 20/20 vision, where you are seeing stuff that virtually no other dentist really sees. I developed this little scale just to show you where dentistry is and where it can go. So on the left, you see the increasing complexity as the pyramid goes up from level 1 to 6. Level 1 is the elimination of infection and pain. Everybody learns this in dental school, and that's the simplest, probably the base level of information that we need as dentists. And then we graduate, and we can do simple treatment of tooth dentistry. In Canada, Walmart is kind of like where you can buy anything for cheap, and that's important. But why is that important in dentistry? Because at this level, patients don't care. They just know that they can get a cheap filling from every dentist everywhere. But if you want to aspire more, you learn to do a little more moderate difficulty. You start treating in sextants and quadrants. Everything is done at ICP. Most of us start where we get to now by looking at more complex aesthetic reconstructions and reconstructions. We begin in ICP. And where we are looking is this level and the next level where it's complex, it's interdisciplinary. We're trying to make the system function better. I know from so many years of doing cases and reconstructions that when you use Visa Concepts and you put the case in and people go, wow, that's good. It's a very nice feeling. It's nice to have the ability to deliver something that people just love. When we talk about aesthetics, Professor Slavicek always said that a well-functioning inclusion looks beautiful. And I think that's very, very important. And the last is what we'll get to here, the dysfunctional system, using a treatment position. A little bit alluded to now, but also then in level 2. Basically what we're trying to do is create harmony for our patients in the muscles, in the joints, and the teeth. Of course, we had to put one picture of the cybernetic model because if you recall the basic curriculum, it's everywhere. The environment affects the organism. The organism interrelates with the masticatory organ. That has the craniomandibular system, the neuromuscular system, and the articulation on one level. We have our functions. The swallow should also be there. And then the body, the psyche, and central nervous system on the other side. And it's always important that we keep in mind with everything we're doing the interrelationship of each component. Last summer before summer school, a number of us did the DCTMD certification course. It was very interesting. It was useful. Perhaps what was most useful for me was in the area of what they call Axis 2, which is the psychological aspect. Graduating from dental school in 1982 and taking psychology in 1977 doesn't help me very much psychologically in my practice. Having the forms from there really helped me out to understand better the Axis 2, or how the psychological component can override certain things. So this is my current mission. Challenged by Christian to come up with therapeutic goals for occlusal medicine as per Visa. So what I did is I put it in this lecture, the very first time I've ever actually spoken about it, to go over with you what our basic, most important therapeutic goals are. And from there, we're going to expand that to review the major principles from the basic curriculum. So what I've done is I've taken general principles that Lisa and Professor Slavicek had spoken about, 8 of those, 8 that are basically relating to the dentition, and 4 to the craniomandibular system. So the first thing we're going to look at are the general principles, and the most general is the first. Patients that present with a healthy masticatory organ must remain healthy. It seems obvious to me and to you that this should be the case. I come from a world in North America where it's not necessarily the case, that large treatments are done without any thought process about function, without understanding dysfunction, and ultimately many people that I see are iatrogenically or dentist-induced problems. So I wanted to make sure that the very first thing is we understand how a patient's functioning, so we keep them functioning well. And if they're not functioning, they're dysfunctional. We have to be able to diagnose it and then know what we do to improve their health. The craniomandibular system reacts to bad forces with a varying ability to adapt. We know that people come in with a class 3 malocclusion with one centric stop, and you ask them how they're doing, and they go, great. And then we know people that come in that have a beautiful looking occlusion. We have to look further, and they're not functioning so well. So there's a variety of different pieces, but we do know that number 4, the masticatory organ will try to function using compensation mechanisms. In the basic curriculum, we talked a lot about compensation mechanisms of the 4 categories, but we're going to be alluding to this throughout our treatments because our goal is to create an ideal, but an ideal is very rare and very hard to accomplish. So we need to understand what we can do in our therapies, using VTOs, et cetera, to understand how we can compensate patients to function properly. So our therapeutic goal is to enhance function, reduce or eliminate dysfunction, and create longevity in all of our therapies. When I graduated, and when I first started studying here, the idea was to have our cases last for many, many, many years. In North America right now, the current standard is to have a crown last about 5 years. That's what insurance companies pay for, therefore it's 5 years. I hate that thought. To me, I wouldn't want to do a crown if it's only going to last 5 years. Why would somebody invest in something that's so poor? We'll talk about leverage in a little bit, but the masticatory organ functions as a class 3 lever. A class 3 lever from high school physics essentially is like a nutcracker. It's the way the mandible closes. And why is that important? Because changes in occlusion, lost teeth, etc., can change that leverage, creating a class 2 or a class 1 lever and creating problems. I know my orthodontist here, this is not right, but orthodontics can improve health, and obviously we must work together, but it can also exacerbate disease. And this is usually by not taking the care that we do, where we mount our models, where we do our cases, we look from the lingual side and make sure the teeth fit. Restorations have to be carefully chosen based on strength of the teeth and their ability to adapt. I'll make some comments today about certain different materials that are personal to me, that I think, and I'll make your brain think a little bit about certain materials as we go forward. And movement of the mandible and function must be understood and respected, which for all of us is obvious. When we look at the dentition on a simplistic scale, we must have even simultaneous bilateral posterior teeth contacts and closure to ICP. In other words, the final part of mastication, the final part of swallowing as our teeth lightly come together. We don't want one tooth to hit, we like them to hit bilaterally in the posterior. We know that Professor Slavicek always commented on the fact that the anterior teeth must be unloaded in ICP. We saw a couple of years ago some excellent research from Japan which showed in functional MRIs in the prefrontal cortex and the limbic system areas fireworks going off when the front teeth hit too hard. I have seen many patients that I have reconstructed where the chief complaint was posterior bite by a little bit and heavy anterior contact, often on restorative materials. In some people, in the wrong person, this can create horrible problems. This is obvious that medial-intrusive, lateral-intrusive, and protrusive interferences can cause dysfunction, and anterior teeth have guidance harmonious to convoluted movement pathways. We'll review that today, but we all, as a principle for these, should understand that. So we must always think of our teeth dynamically and what happens when the patient moves in 3D. Again, carrying on with the teeth. The spherics of occlusion must be respected, curves of Spee and Wilson, because if you don't, teeth don't close together properly, they don't function properly. Our posterior tooth contacts are cusp and fossa, and load the teeth axially. And excursive contact should almost never exist on molars. Why did I put almost never? Because there is some thought process that if you have degenerative joint disease, no discs, having a balanced occlusion, which sometimes nature will create, will support the joint. In other words, creating guidance in that situation may cause problems. Professor Slavicek in his last book had talked about a balanced occlusion. He spent one nightmarish week here trying to wax a balanced conclusion. I didn't succeed, but it was very, very tough to do. Apparently possible. Excursive movements of the mandible are guided by optimal sequential guidance. That we understand, and that falls into the category of functional geometry, which we'll review. Again, the very first sign of dysfunction are muscles. They're the bellwether of a problem. Slides from RCP to ICP are less than 0.5 millimeters at the level of the condyle. And what does that mean? That basically means if you take your knuckle and your finger and you pull it a little bit, that's about 0.5 millimeters. So we don't consider that to be too big a deal at the level of the condyle. Note, we're not talking at the level of the teeth. We're actually assessing that at the level of the condyle. Retrusive movements exist in bruxism and function. If we don't understand that the mandible that goes forward can keep going back, we create problems. And if we don't build guidance into especially diseased joints, we have problems. And the final one is the repeatable starting position for diagnosis, reference position, and an understanding of the craniomandibular system and dysfunction necessitates potentially a different treatment position sometimes. So all of these are the essential concepts that we have to understand. They're the, I think, foundation of what Professor Slavichek taught us, and the foundation of my little review today, and everything that we talk about for the next 2 years. But above all else, in all of our treatment plans, we have to make sure that we are going in a positive direction, not a negative direction. So those are the goals. I have that actually, I can send to anybody that wants. I'll share everything with you, and there's a PDF I think you have with all of that. The diagnostic workflow. I'm always asked, how do I integrate in my office VISA principles? So I put this in here just to kind of go over where we go. So if a new patient comes to my practice, usually in my practice it's referral. They either come with a problem, or I have to deal with that specific issue, or not. If they don't, I go right to the small functional analysis. Now, as of yesterday, we reinvented the name small functional analysis to standard functional analysis. Thank you, because nobody liked the name small functional analysis. Nobody really understood it. But after Christian explained how it was translated from German to English, that's how Professor Slavichek came up with small. So the new words that we're going to use are standard functional analysis. And of course, these are the elements that we're going to include in our standard functional analysis. From there, I will decide whether a patient needs X, and if this is the very first appointment, or second if it's emergency. Anybody I see on emergency, I tell them, I'm happy to solve your problem, but you must come back for my evaluation. I don't want to miss anything, I want to do my best care. So I have multiple different opportunities to do further diagnosis, which we'll talk about. So this is the overall VISID flow. So we know we have systematic data collection, we have our interview with the anamnesis and the dysfunction index. So our standard functional diagnosis will include all of these, which I'll go through, the enhanced functional diagnosis, additional diagnostics, and our interdisciplinary planning. And the question is, when do we do this? Which I will review briefly. Professor Slavichek always said the number one thing, the most important thing, is we sit with our patients. We all know that, and we ask open-ended questions. So we're going to come up with the occlusal index or dysfunction index in the anamnesis. All of these items must be done, and this is what we're looking for as the standard functional analysis, including the range of motion. Each of my patients coming into my office, it's an adult, I will go through each of these things. The one thing I may not do is a Brux checker if there are absolutely no symptoms, but many people have symptoms even at any age. If I determine that there are problems, and these problems can be one of two things. One, I've identified that there's dysfunction. Or two, it's a large case where I want further information and I know I will want a hinge-axis transfer, or I know that I'm going to actually be going to more of a reconstruction. Of course, I want my condylography, if nothing more than just to set my articulator. I will always go to the enhanced functional diagnosis, that's the new word, enhanced as opposed to large. And do condylography of the hinge axis, RP, obviously the condylography, and my Ceph and Cadius analysis. Because of course, I wanted to use the part of the Advanced Document Browser for my VTO. If necessary, we will do the additional diagnostics. A challenge for me in Canada is that I can easily get a CBCT, but not an MRI. So some of my cases, it's a challenge because it can take months to get an MRI, believe it or not. In interdisciplinary planning, I work with a wonderful periodontist, a very good orthodontist, good oral surgeon, and orthodontist. My physiotherapist, unfortunately, is just retiring after so many years, so I'm now looking. So now that we've done that little introduction, I'm going to go through the next part fairly quickly because you already know it. But when you're trying to put together a review, you don't know where to start, so we're going to start with the most basic things. If I am boring, I apologize. It will get more exciting eventually. So we know the basic tooth movements. We know that medial obtrusions at the level of the condyle. Our medial obtrusive and lateral obtrusive movements are at the level of the teeth. We know that there is protrusion and retrusion. And we're going to look at lateral protrusion and the various synonyms. I use this diagram in all of my early lectures for people because it's, in North America, nobody understands what medial obtrusion and lateral obtrusion are. They think of working and balancing. So if nothing more, you'll know what the North American standard is. But right medial obtrusion obviously is the condyle going right, or sorry, to the right condyle moving medial obtrusively. At the level of the teeth, the medial obtrusive side is on the side that is moving, and the lateral obtrusive side the opposite side. In North America, this is what it looks like. We have the balancing side, the working side, we have the orbiting condyle, and the rotating condyle, and the orbiting condyle. But let's transpose that to the teeth, and this is where it gets a little bit more interesting. Have you ever thought about teeth as they age and as they wear? It's fascinating for me after watching 41 years of people's teeth and watching my own patients, many have had for 41 years, and watching the deterioration that's occurred right before my eyes. So I took it myself to think about why do teeth break and what do we look at? So we're going to study this tooth here, tooth number 3-6. Typical 3-6, large amalgam. We'll zoom in on it a little bit. So when we look at tooth 3-6, from the top, we see, of course, 5 cusps. We have mesiolingual, we have mesiobuccal, distobuccal, distal, etc. When we flip it up on its side, what we see is the distobuccal cusp is the tallest cusp. So we're going to study that tall cusp, and we're going to say the tallest cusp probably has the most chance of interference. When we look at the upper tooth, we're going to see the mesiobuccal, distobuccal, mesiolingual, and the distolingual cusps. And we flip that guy, and we see the mesiopalatal cusp is the largest cusp. And it probably has the biggest chance of interfering with the lower tooth. Before we look at how it interferes, let's look at a little bit of research from Lundin and Gibbs on the function of teeth. I think this is very important because this research came out about 78 to 82 when they used their Mathic replicator with a mainframe computer. And much of the information was forgotten, but is beautiful to read. You can watch YouTube videos about the research. But the duration of contact and function for most people in their research was 4 to 10 minutes. In bruxism, it was 4 hours. So your mind thinks, gee, which of these two things probably causes more damage to teeth? Obviously bruxism. What about the magnitude of force? Well, in functional movements, we know there's not a lot of force. It can be 20 to 40 pounds per square inch, sorry for the British saying here, and up to 300 pounds per square inch in bruxism. Again, no problem. Functional movements tend to load teeth axially, but bruxing or functional movements tend to go horizontal lateral. Again, this creates more friction than that, thus wear tends to be more critical with bruxing. When we look at the leverage of function, class 3, as I'll show you in a sec, is the type of leverage that the mandible should have. But in bruxing, we often will get class 2 or class 1 levers. The muscle contraction is isotonic, and this means a normal motion where you're actually moving your muscles, exercising your muscles in your joints, lubricating the